Yeah, there absolutely is. The population that's talked about a lot are people of African origin, specifically people of West African origin. This is what's been best studied. So we know that in this country, African Americans have about a 2 to 3 times higher rate of developing myeloma. It's actually, we talk a lot about other cancers, but it's actually the most disparate cancer in terms of how often it affects African Americans. More than breast cancer, more than prostate cancer. So if you go back and look at people who have MGUS, MGUS in West Africa, there's actually a 2 to 3 times higher rate. So this is most likely not a thing of environment, but most likely a thing in our genes. And there are populations that seem to be less affected.
Yeah, double in blacks, half in Asians. So there clearly are factors that are, I think, genetic or epigenetic.
What is epigenetic?
So everything's not in the genes. I mean, there's things that regulate how genes get expressed and which proteins that they produce that are not the gene itself. It's the way in which, all the genes in your DNA aren't actively making proteins at any one time. There are times that they are and times that they're not. The hemoglobin you make depends. It's different when you're embryonic and a baby and then a young adult. It keeps changing as genes turn on and turn off. And the regulation of those genes, that's called epigenetics. So there are things about regulating the genes that are really poorly understood that may be contributing to this racial disparity in the incidence of monoclonal proteins. Yeah, so here's the deal with dexamethasones. You go back 30 years before there was anything and you wanted to transplant a patient, if you gave dexamethasone alone, just dexamethasone as a single drug, you got a response in half the patients. 50% of patients had a 50% reduction of the protein dexamethasone alone. Dexamethasone kills myeloma cells, period. It kills them. And so it's not anti-inflammatory or enhancing. It kills myeloma. And it's nice because it doesn't damage the nerves in your feet, and it doesn't affect your blood count, so all it does is make you crazy. And that toxicity is most usually expressed by the life partner and not the patient. How's the dex going? Oh, it's good. I'll kill him. So dexamethasone, because its toxicity isn't visible to the provider, is usually incorporated. And people are on dexamethasone with every regimen for years and years, even if it's clear dexamethasone clearly isn't working at all because they've been on it for 8 years. So for crying out loud, quit it. And I think what happens with very experienced physicians is they quit looking up in a menu and saying, oh, here's what the dose is, but kind of eyeballing the patient and say, oh, if I give them 10 dexamethasone once a week, I'll kill them or they'll kill me. One of those two will happen. And so, oh, I'll give you 5, I'll give you 3. And even though it's regulated in trials, in practice, if the patient's having a lot of toxicity and they're already responding, it's like, okay, well, you don't have to stay on that dose. We're going to cut it down, and we're eventually going to discontinue the dose. Experienced practitioners aren't adhering to the NCCN guidelines or what they read in the most recent review publication. Their experience realizes that treatment of cancer is this balance between efficacy and toxicity, the side effects of the treatment. And if the cancer's good and the patient's miserable, there's a problem there. And it shouldn't require tears and negotiation on the part of the patient with the provider about, please take me off it. That ought to be, okay, Let's kind of move it down and get rid of it, because it's not the dexamethasone, of course, it's the dose of the dexamethasone. That's the real issue. And that goes to the very beginning when Greg was talking about the second opinion and the experience. So I saw a patient Thursday from Chicago, interestingly. And the patient had a really magnificent response to treatment, but really had very bad neuropathy. It was really, really bad. And he came to Mayo. Why'd you come to Mayo? He'd already had induction, transplant. Well, they want to put me on Velcade maintenance, and Velcade gave me my neuropathy, and I don't know what to do. And I said, don't take Velcade. I mean, it was a 20-minute consultation. It's crazy. You've got bad neuropathy. You're going to go back on Velcade and make it worse, and then you won't have myeloma, but you'll certainly be miserable for the rest of your life. And so they just, I guess, came for permission to exercise judgment and not say, well, but the rule says that if you're this risk, you've got to get this, and that there's just no wiggle room. That's judgment, and you don't get judgment in the textbook chapter. That just comes with years, which I have a lot of.
I wish Jenny was here, because Jenny, as a myeloma patient who has taken a lot of dexamethasone, her comment about dexamethasone is it's the drug that makes everybody else stupid.
So, we're being taped. Let her watch the replay. No, wait, Dr. Patel hasn't had an opportunity.
Oh, I'm sorry, did you?
Oh, I 100% agree that if you're having intolerable toxicities from dexamethasone. So if you tell an internist, I give someone 40 milligrams of dexamethasone once a week, it's about, I think, 250 milligrams of prednisone. So,
But that's not even true. You know it's not true.
No, it's not true.
If you gave him 250 of prednisone, it'd be much less toxic.
Yeah, it is, absolutely. But here's the thing, you tell them that number, and my friends who are internists almost choke on their saliva, because it's a ridiculous dose. It's a ridiculous dose to ask people to take year after year after year. So, no, the dose has to be quickly de-escalated if you're responding and if you have toxicity. I think actually the only point I have to add, so I totally agree. The only point I have to add is that there are some people out there who aren't even applying the textbook, but are using bigger doses. And that, to me, is a big problem, because this is well studied, that when you use really big doses, it may work for the myeloma, but you kill people from side effects. So that's the only thing that I would add. That, yeah, you've got to de-escalate dose, but there are some people already starting at doses that we've known for 10, 15 years are not the right doses to use.
Someone asked earlier in the group about using a drug, solumedrol or methylprednisolone, which is also a steroid. And I think that's actually quite reasonable. I mean, the question is maybe not dex, but a different, in the same drug class of corticosteroids. That's reasonable. The British, in a similar disease, amyloid, have stopped using dexamethasone and have substituted methylprednisolone. So there's just a lot of ways, if you have enough knowledge and experience, to modulate what's going on. You just don't have to suck it up. Then you gotta go and get it in writing from someone that has some credibility about what needs to be done. I mean, you just have to get off your butt and get the opinion. I mean, if you can't convince the doctor yourself, then you're going to have to get another doctor to convince the doctor.
So the stuff that I talked about, this fitness and frailty thing, I think that's one piece of it, for sure. Those are not, they're objective, but it's not like a test that you order. I think you have to be in front of someone who's experienced, either an experienced myeloma person or even an experienced transplant doctor who knows who can safely undergo these things. But then also, for everyone who undergoes a transplant, there's a whole set of workup tests that partly are looking at how fit you are, but also partly are looking to show your insurance that you're fit. Most centers have a standard list of those. And at minimum, most of them look at your heart, your lungs, and a couple of other ancillary things that really are very insurance-based. And that's really the majority of the testing that you should go through.
What's your age cutoff?
So I do not have personally an age cutoff, but
What's the oldest patient you've transplanted?
me 75. I think our program's 76. But I'll even though I don't have an age cutoff, I think that insurance thing that I showed you is very important to me, because I think if you're 75 and you have 15 medical problems, and unfortunately your life expectancy, according to that table, is on the order of a few years, there is absolutely, even if I think I could safely do the transplant, which is unlikely, there's absolutely no way that I would recommend it. So I think the number has to be put into the context of how long I'm expecting someone to live. So if you're 70 and you're going to live 20 years, then why should I be saying no?
So yeah, that works. Yeah, our CAP's 77, and that's full dose melphalan, and 2 of our 77-year-olds did it without a day in a hospital. And yeah, well, it just depends. There's obviously a lot of selection that goes on in those patients. But really what we're saying is the big deal about transplant is we don't want to hurt you. I mean, that's the thing. And so if we go and saying we know transplant is superior, but not at any cost, and so that if we can get you safely through a transplant, safely, and we really predict that the risks are low, we're going to go ahead, you know. And age 75, that wouldn't even make me blink, because that's getting younger and younger for me, actually. So, and I don't know what the Medicare cutoff is, actually. Is it 77? Oh, no. We've done 76 and 77 without, transparent to me anyway. So we've gone through, I didn't actually know that, but we've done over 75. But, you know, like there's another disease I deal with that's kind of like a second cousin to myeloma called amyloid. We turn down 2/3 of the patients for transplant. We only transplant 1/3 of them because we think we're going to hurt you and it's not going to be worth it. That's the end of the day. We can't guarantee you're going to respond at an individual. I know 100 patients will do better than 100 patients who don't, but we don't want to hurt you. And so if Dr. Patel thinks you're too infirm, your heart's not quite up to it, your lungs aren't up to it, you harbor chronic infections or some such stuff, it's just not going to happen.
I think it's really what doctor you're seeing. So I'll tell you what I do and why I do it, and maybe Dr. Gertz might disagree. So the maintenance data, really, I think mostly we have data looking in large studies at Revlimid, and in particular 2 very large studies that support that Revlimid after the transplant keeps you in remission longer, and in one of the studies keeps you alive longer. There is also a study of bortezomib where there are similar findings, not as big, but similar findings. I believe that most people would say that Revlimid is the standard of care in not only in this country, in Europe as well, after the transplant. Now, in higher risk, some people may say you should get bortezomib. Bortezomib use is really limited for long durations because of peripheral neuropathy. And in those studies, we're talking on the order of 2 to 3 years, but half of people did not make it to that time because they developed peripheral neuropathy. Now, Revlimid definitely has side effects, but it doesn't tend to have the same cumulative problems. So in these 2 big studies, one study stopped after 2 years, and we can talk about why, but one study stopped after 2 years. That was a study done in Europe. The study in this country continued. For this reason, and looking at the results of that study, I tend to continue. Now, on the flip side, some people say, well, there are people who underwent transplant before maintenance, and they stayed in remission for many, many, many years. We do not have any way of predicting that, and for that reason, I recommend people to continue. There are some folks who say, look at the MRD status and maybe stop. I don't think that's data-driven at all. So my preference, therefore, is to continue until there's a problem or a side effect that needs you to stop.
That is actually what I do. But again, this is a negotiation with the patient because you're talking to your patient. And it's the same as the dexamethasone, efficacy versus toxicity. So the treatment's working. Then the question is, well, how are you tolerating it? And so, and again, the scientific correct answer is minimum 2 years. But then after that, it's like whatever you do is okay. But in that situation, if it isn't broke and they're stable, I'm not in any rush to stop it. But there's some patients who have really a lot of fatigue that's not amenable to dose reduction. They're just tired all the time and not feeling at their best, and they really don't want to be on it. Well, that's okay. I have my way of doing things, but it's not scientifically based. If you want to get off it, we'll get you off it. But I will tell you the flip side, because we've had access to these drugs as an investigational agent for a very, very long time. I have patients who've crossed the 10-year mark on Revlimid maintenance, continuous Revlimid for 10 years. And you say, and they're MRD negative, and you say, I don't really know if we're doing anything at all at this point. And they go, yeah, I'm happy. Let's just leave it where it is. It's got to be a patient-driven decision. This is not a situation where I'm telling the patient by that amount of time, it's a two-way about what they want and what I think.
It's not really. I think there are people amongst us who really try and advocate and say that that's not acceptable. Our problem is that we want to do the best for people, and I think sometimes I say, well, I can't focus on that. I understand that the bill hits your doormat and that's unacceptable. I think that's why we shouldn't do things. Personally, I shouldn't be ordering tests that I don't think are actionable, meaning if the result isn't going to change what I do, then if it's pricey, why do I do it?
Healthcare economics are unsustainable the way they're going. We're 20% GDP, double the nearest competitor country with no improvement in long-term survival in this country. And higher infant mortality and women dying in childbirth than other countries. We're like 40th on the list. Were you on maintenance therapy?
Yes.
So I'll tell you what I'm doing currently. So usually it's VRD, transplant, and maintenance Revlimid, lenalidomide. People break through. If they responded to their initial VRD, then I'm assuming that the V is still working. And then my next go-to, because I'm so impressed with it, is the daratumumab Darzalex. And you'd end up, if you were in my practice, in that situation, probably on DVD, daratumumab, bortezomib, dex, Velcade. Tell them what you do.
Yeah. Yeah, no, it's a tough situation because we know that within a couple of years, we know that that's a poor prognostic sign. So definitely 3 drugs, absolutely. I would opt most likely for a daratumumab-based combination. I tend to use, in this setting, daratumumab pomalidomide, dexamethasone.
Oh, totally reasonable. And someone would use daratumumab, Kyprolis, dexamethasone. I mean, that would happen, but they're all kind of reasonable. And some people would use Kyprolis, Pomalyst, dexamethasone. I mean, there's no one right answer. And so if someone does something different from what I do, it's all fine. I'm telling you, that's actually what I would do is daratumumab, Velcade, and dex. But any triplet of agents that you don't suspect resistance to should be legitimate. Be a great time to get on a clinical trial, though.
Yeah, it is. So there are people who come along with multiple areas of bony disease, and they don't all need to be fixed per se. The fix is treat the myeloma, stop the bone loss by treating myeloma, and then have you on a medicine that will also help with bone loss. So Zometa is probably the most popular one that's still used. We tend to not know what to do with Zometa after a couple of years. Most of the studies go out to 2 years, and then we're all kind of like all over the place. I will tell you, if you didn't have a lot of bony disease, in my practice, I'd say, you know what, you had 2 years, this medicine stays in your bone for years and years, I would stop it. Some people say, well, maybe you should get it every 3 months. Other people say, oh, you continue. It's all over the place after 2 years, but at least a couple of years of bisphosphonates.
You look great, and it is totally realistic to believe that you've healed. And what I do with the Zometa, it's not just the 2 years, but it's how deep's your response. Because the likelihood of having a myeloma skeletal event, if your myeloma is under spectacular control, is low. And so if you've got a relatively deep response at 2 years, I'm calling it quits, because I worry about some of the side effects associated.
So by consolidation, do you mean I got my induction therapy, I had a transplant, and then I'm being offered more treatment after my transplant?
Yes.
And when you say more treatment, you mean not just a little dose of something, you mean full doses. If I went back in time a few years, I would say this was something that was done a lot. Based on, there was some single arm studies, so meaning it wasn't a coin flip, everyone got the same thing. And if you looked at folks who got a transplant and then got some more treatment afterwards, it looked like their responses got better. So especially, some people are saying, well, especially in higher risk disease, especially if you hadn't had the response we want, we're going to do a consolidation and then put you on maintenance. I go back to that study that I told you about, that really big study where there were 3 different therapies. Now, in that study, you have to know that this study was done in this country, so people were referred from their, by and large, community oncologist. They'd had a decent amount of treatment up front. I forget, 6 or 8 cycles. I think 6 was the average. Then they had a transplant. Then the people who got consolidation did not do better. So this is one of the hard questions in my practice, because I think, well, this person didn't have the response I want. Should I do more? The data by that huge study, to me, doesn't support it. And it's kind of analogous to this MRD situation, because we think, oh, yeah, MRD positive, that's bad, let's do more. You don't know that you're affecting a lot of change. Yeah.
I'm the same. I don't use consolidation in my practice at all, because that trial demonstrated that transplant consolidation, transplant maintenance made no difference at all. So I said, well, I put people through it. There's another thing I look at, and that is the consolidation was the same as what your induction was. So that's important. So I actually look at the pre-transplant induction, and I look at the proteins. And if the proteins are doing this, and then you went to transplant, I'm thinking, gee, maybe if we continue to do that. Typically not what you see, though, because the drugs work so fast. What you typically see is it goes, and then it levels off. And it levels off like this, and then you go to transplant. And I say to myself, well, it already leveled off after 2 treatments. I gave 4. Where am I going with 6 more afterwards? It's leveled off. And so I do look at the pattern of which the protein goes down, but by and large, you don't get consolidated in my practice.
Yeah, I think you have to ask yourself, there's 2 questions, with 2 points to this. I think, yes, things get better. We oftentimes tell people, oh, you get out of the hospital. No, it's not true, right? There's a significant recovery, and some of those things, especially I find fatigue, people can complain about 6 months later. Studies that show a year later, people still have it. So oftentimes the more you do, stuff like that improves, and life does improve over the long term. But it's important to consider whether maintenance is contributing to your symptoms. And exactly the same as the steroids, if it's miserable, the dose can be reduced. Oftentimes, early on, we don't know. Reduce the dose. If you feel better, maybe we can go up in 6 months' time. But there's no point in going through the misery of side effects. I think the other thing is also to get back to the point of dose reductions. We dose things based on side effects. We are not dosing it based on this has a biological effect. We looked at it in the study, and you need this dose. So sometimes we, as well as patients, fixate on, hey, I was on 15, I was on 10, that's really important. We don't know how important that is, actually. So don't suck it up.
So maintenance, I wouldn't short sell its contribution. So the frequency of fatigue on Revlimid maintenance, I think, is half. I mean, there's a lot of people who notice it. And even people, I've had it many times, who say, I'm having no side effects from Revlimid, having no side effects from Revlimid at all. And then for whatever reason, they stop the Revlimid, and then they come in and go, God, I'm feeling better. And I go, what are you talking about? You told me you were feeling fine. He goes, I didn't know until I stopped it. I really didn't know how the fatigue was. And what Dr. Patel mentions is really an important thing. When you develop drugs for cancer, all of the testing is designed to determine the maximum tolerated dose. That's what we're giving you, the maximum tolerated dose from the trials. That's not necessarily the same as what you really, really want, which is the minimal effective dose. Those two are not necessarily the same, but it's a lot easier to figure out what the maximum tolerated dose is. We're going to keep increasing the dose till you get sick, and then that's too high. But that doesn't mean that that dose is the only effective dose. There are options, and they really, if you have no side effects, what's the point of changing the dose? I mean, you're doing okay. But if you are having side effects, that's that negotiation and experience and dialogue of, I'm not living the life I want to live.
You know, there are actually studies out there on fatigue at a year. So I think we always say tell people 3 months, 3 months. But when you look at the quality of life studies, 3 months people aren't back to normal. 6 months maybe, but there are still studies on fatigue at 1 year. There are also people who have studied the impact of exercise and maintaining muscle strength and doing stuff around the time of transplant actually reduces that long-term fatigue. So I know it sounds like we kind of say, oh, do more then. I can't do more. But I do think it's important to push yourself. I think analogous to what we showed, that when the disease comes back, especially if it comes back early on after transplant, that you've applied this selective pressure, and what comes back, if we're talking about within a year, 2 years,
Okay.
then it's probably we're talking about resistance.
So therefore, any treatment theoretically can increase resistance.
Okay.
Not
Yeah.
just transplant. Yeah, it's really beyond the scope here. No, it doesn't go to the brain.
Okay.
The amyloid of Alzheimer's is not related, but it really is, you have to go to a different support group meeting, frankly,
Okay.
if you want to do amyloid, because
I don't.
for most individuals, it's not relevant. It's a very, very different disorder, and it's a much more complicated weeds and garden talk. It happens occasionally. I'm telling you, it's quite rare. It
Okay.
does happen where someone can have myeloma for 6, 7 years and develop amyloid. It's very, very unusual, and you have to see hundreds of patients to actually see it happen.
It really should be judged on comorbid conditions and how fit you are. 200 milligrams per meter squared, to me, is the standard dose. I think you should get 200 milligrams per meter squared unless there's a compelling reason not to. The most compelling reason actually is kidney disease. Even then, there's data to show if you get the full dose, you basically get a bigger exposure. That bigger exposure in many people equates to a longer time in remission. It equates to some more side effects too, but equates in some studies to longer time in remission. We're not good at understanding the disposal of that drug, melphalan. It's really variable. And so it's kind of, you go to different centers, people do different things, but this is what I do in my practice.
Ditto 200, but not until I've actually laid eyes on the patient.
Yeah, it sounds like you're getting some side effects. To me, using steroids persistently in the maintenance phase, if you're feeling miserable, I don't know. Really, it sounds like you need less steroids. I think that's probably the weight contribution at least. Fatigue for sure can become from I think fatigue could also become from steroids, honestly, if you put on a lot of weight and not able to do as much as you need. So it sounds like you really need dose reductions here. Now, I'm sure there's some thinking behind why you're on these things, but it needs to be a conversation about reducing doses to me and even stopping steroids.
Yeah. It's a conversation. I mean, it's not about, well, your myeloma has this biology and therefore this is the recommended treatment for every patient. You're not feeling well. You're, at least from a pure employment standpoint, non-productive. You'd like to be able to go back to work, and the medicines aren't letting you do that. then myeloma is not the problem. The medicines are the problem. And then there has to be some negotiated modulation so that you achieve, I mean, part of the goal, you're talking about cure, well, you know, who wants to be cured if you're feeling like crap, you know? I mean, you need to feel reasonably well. You're young. Is this how you're going to feel then for 20 more years? That's your prospect? Or you actually speak up and say, I can't take it. No. 22% at diagnosis, 3/4 of patients who get treated with today's therapies will have their kidney function improve further. And at the time when you go to transplant in our practice, only 5% of patients still have persistent kidney disease. But the other piece of this is that if the light chains didn't damage your kidney in the diagnosis, it's highly unlikely it'll damage it at the end. And which reminds me of a caveat I was meaning to bring up. Someone brought up about the 1,000 light chain being worse. So it's not prognostically worse, but it certainly does increase your risk of having kidney-related injury from the myeloma. If you have a light chain of 50, your kidneys are going to be fine. But if you have light chains of 1,000, it doesn't affect your overall prognosis, but it definitely increases the likelihood that you could be diagnosed with harm to your kidneys. So it's a caveat of what was written in the back before you revise the whole thing.
No. Now, Velcade super rarely can. Actually, more of a culprit in the proteasome inhibitor world would be carfilzomib. What it tends to do, it looks like, hey, yeah, it might stop the pump function being as good, but actually it looks like causes a lot of high blood pressure, which causes the heart muscle to thicken a lot and become a bit stiffer and not stretching as well. But calcification, not as far as I'm aware.